Ministry of Health and Family Welfare. We welcome you all to this yet another webinar on the National NPNCD National Webinar Series. The topic for today's discussion shall be regarding the World Asthma Day, which falls on the 6th May 2025. So it is commemorated on first Tuesday of the month of May. The day basically aims to raise awareness about asthma and the importance of properly managing this chronic respiratory condition. And it is an opportunity for us to, first of all, educate ourselves, our friends, family, patients about asthma and promote awareness about how this serious, life threatening chronic respiratory condition can be controlled, diagnosed, and of course, controlled. The theme for this year's World Asthma Day is make inhaled treatments accessible for all. And the theme holds uh, huge significance in the fact when we talk about affordable, accessible, universal health coverage measures. So it is important to have the diagnostic and treatment facilities for diseases accessible for all. Today, as our expert speaker, we have Professor Sanjeev Nair, sir. Sir is a faculty at Department of Respiratory Medicine, Government Medical College, Trivandrum, and is one of the eminent experts on respiratory diseases. We are fortunate to have sir with us, and I would like to request sir to kindly take over and enlighten us regarding the theme and the importance of early detection and treatment and follow up for chronic respiratory diseases. So over to you, sir.
Yes, sir.
Thank you, Dr. Avinash. Thank you, Dr. Pankaj, for organizing this event on World Asthma Day, as well as for inviting me. I hope that I'm audible.
Yes, sir. Absolutely clear.
So let me share my slides. Are the slides visible?
Yes, sir. Clearly visible. Please go ahead.
Thank you. Thank you again for the invitation, and let us start without wasting time. I believe that we have half an hour for the session. I'll try to finish in 20 25 minutes. Uh, so, as aptly pointed out by Dr. Avinash, this year we are having the theme of making inhaled treatments accessible for all. Now, this is not an easy task, and I must congratulate the NCD division, Government of India, as well as various state governments for having taken this initiative forward. And now that, at least in many parts of our country, inhalers are available for all. There was a time when access to inhalers was very difficult, particularly in primary care, but then things are changing for the betterment. And when I visit other countries in the world, I have realized that this facility is actually not available in many countries in the world. So India is, now becoming a front runner, and we are making significant progress in this regard. So in today's talk, my plan is to discuss a bit on what is the burden of asthma in our country, why we should be discussing asthma today, and why asthma should be given importance in our country. The diagnosis and treatment of asthma in brief, because time doesn't allow me to go in detail into all those things, but at least the key points in that. And also, if time permits, that part is based on how much time I have left, I might discuss a bit on the efforts from the national government as well as the state government, particularly in my state, on taking asthma care down to primary care level. Generally, asthma care for years remained a specialist area with GPs practicing in a very different way. But now, with efforts from both state governments and government of India, we are taking this forward to even primary care level at high quality without compromising on the quality of care. So going on to the disease burden, as you can see here on the slide, just give me a minute on this. So you can see asthma here as a small rectangle, but then it's not very small. It's more, asthma causes more mortality than many of the other causes like what we have put here. We'll come into that later. But the point to be made is that asthma is still a significant cause of mortality in India. Of course, it is overshadowed by COPD, which kills more people in India. And COPD is the second leading cause of death in India. So we'll be slightly discussing COPD and asthma together because when we manage these diseases together, they go hand in hand. In terms of suffering also, DALI is the disease morbidity. In terms of morbidity, symptoms, activity loss, and also asthma remains an important disease in that aspect. So both for death and suffering, asthma is an important disease for our country. So this is, something I took from the GBD. So this is called global. All the pictures that I'm taking out is coming from a site called Global Burden of Disease, which is endorsed by ICMR and Government of India for disease burden estimation. And you can also access the site and get all these information. So the thing here is that certain diseases, mortality is on the increase. For example, coronary artery disease, COPD, stroke, and asthma is also a disease for which mortality is on the increase. Whereas for certain other diseases, like for example, measles, which was a top 10 cause of mortality in 1990, now has gone beyond the top 100. So certain diseases we have made significant progress, whereas certain diseases, the mortality is actually still on the increase. Slightly older slide who gives 2019 data as compared to 1990 data. So if you see in 1990 and in 2019, in the world, you can see that the major cause of mortality remain pneumonia, COPD, TB, and lung cancer. Lung cancer is going up the list in the world. Whereas if we take our own country, pneumonia, TB, and COPD remain the major cause of mortality in the top 10. But just below that, you can see asthma, which is not there on the global chart, mind you. So it is there on our Indian chart, remains at number 14, number 15 cause of death in India. So the point being made is all over the world, asthma is not that high a cause of mortality. Whereas in our country, India, asthma is a significant cause of mortality. Again, this is shown in a different way in the map, as you can see. If you look at the mortality in various countries, the Western countries and all, the mortality due to asthma is quite low. Whereas in our country, the mortality due to asthma is higher. I put up a chart of, various mortality, which will come in the next slide. Again, if you look at this in a different way, if you look at the prevalence of asthma, you see the slide on the right side, I mean the graphs on the right side, you can see that the burden of asthma is more or less similar between the high income countries, upper middle income, and lower middle income countries. But when it comes to mortality due to asthma, major chunk of the mortality is contributed by the lower middle income countries, which actually includes India. Again, I put up country-wise estimates from global burden of disease. So you can see the highest asthma mortality is in Fiji, but India is also not far behind with about 14.6 lakh, 14.6 people dying per lakh population due to asthma every year in India, as per the GBD estimate, slightly older estimates, as compared to the global estimate of 5.5%. So all over the world, people do die of asthma, but in India, 3 times the number of people dying of asthma is there. And when compared to the USA, where only 1.2 per lakh die due to asthma, the people who die of asthma in India is almost 12 to 13 times that number. Which means that if we manage asthma properly in our country, we could significantly reduce the mortality due to asthma in our country. And this is eminently doable. It's not that it is very difficult. The theme goes that you have to give access to inhalers, and if patients get the right treatment, you can significantly reduce the mortality due to asthma. One of the GBD, one of the Sustainable Development Goal targets is to reduce mortality due to non-communicable disease. You are all working in the field of non-communicable disease, and this is a very important way of reducing mortality due to non-communicable disease. In terms of state-wise estimates, if you look at it, it is the states of Rajasthan, UP, and Uttarakhand, which have the maximum burden of asthma in our country. And in terms of diabetes, also disability and adjusted life years, also suffering, also it is here. Rajasthan, Uttar Pradesh, Uttarakhand, and Himachal, which have the highest burden. So it varies from state to state, but certain states have a higher burden. Now let us move on to how we diagnose and manage asthma in brief. So, like I said earlier, I'm taking our COPD and asthma together. COPD, as you know, is a heterogeneous condition which has chronic symptoms, abnormality of the airways and alveoli, which is progressive. Whereas asthma is a heterogeneous disease which is characterized by chronic airway inflammation, it's defined by a set of respiratory symptoms, particularly wheeze, shortness of breath, chest tightness, and cough, which varies in intensity together with variable airflow limitation on spirometry. Uh, if we don't manage it properly, the airflow limitation, which is variable in asthma, can become persistent just like COPD. So that is the challenge that we are trying to avoid. The key word in asthma is chronic airway inflammation. So the point is that the airway inflammation is present. This airway inflammation is responsible for the hyperreactivity in asthma, which causes repeated symptoms. And unless and until we control the inflammation, you cannot make your patient better, and the patient could be suffering from asthma. Am I audible? Am I still audible? I had an electricity problem here, so I'm just wondering whether my net is still there.
Yes, sir, you're audible. Please go ahead.
Okay, so I can still go on. Sorry, the net is still persisting. Okay, thank you.
Whenever any challenges will get, I'll
Yeah.
let you know.
Okay, okay. So, uh, so the point here is that when you have chronic airway inflammation, what you need is a long-term anti-inflammatory treatment. The best possible treatment for inflammation is corticosteroids, so steroids. But the problem with steroids is that steroids have significant side effects. So you need a long-term treatment, but you have to take care of side effects also. And for that reason, we give steroids in asthma as inhalers. And by giving as inhalers, you can reduce the side effects of steroids, and you can give it long-term to your patient with minimum side effects. Because we should understand that in our country, inhalers are often viewed with suspicion, but there is no treatment for asthma which can be done without inhaled corticosteroids. So why should we differentiate? We always teach our undergraduate students, MBBS students, to differentiate these diseases. This is because these two diseases are different, and the prognosis is different. So if a patient coming with COPD, his symptoms will keep on increasing or be persistent. Whereas a patient with asthma, if you manage him properly, patient can be made near normal. Patients, all symptoms can be controlled. The treatment is also different. Now, how do we differentiate? There are a set of symptoms you look for: age of onset, whether there is associated atopy or not, whether the symptoms are episodic or persistent, whether there is family history or not, whether there is exposure to things like cigarette smoke, biomass fuel, and all, and finally spirometry. So, by using these tools, you can differentiate between asthma and COPD. Because of shortage of time, I'm not going to detail. Once you're differentiated, the main advantage thing is whenever you have diagnosed asthma, the minimum or the essential treatment for your patient is an inhaled corticosteroid. And whenever you're diagnosed COPD, the essential treatment are bronchodilators, and inhaled corticosteroids can be given only with specific indications. So treatment is very different. In our country, often people mix this up and give treatment as if both diseases are the same. So when you want to diagnose asthma, the most important part is the history. So you have to sit with the patient and elicit a proper history, and this is very important. The main points you're looking for is the nature of the symptoms, whether the patient has triggers. Triggers are, somebody is having dust exposure and suddenly he has dyspnea, or he has cold exposure and he has dyspnea. So any kind of trigger which increases the symptoms, strong smells, emotions, and all, that is, helps to make a diagnosis of asthma. And presence of a family history, which should be a longer family history. You don't just ask whether father, mother have asthma. You ask for brother, sister, uncle, aunt, grandfather, grandmother. So take a full family history and try to. And of course, finally, you do a spirometry to make a diagnosis. Certain symptoms suggest that, this could be asthma, which include, more than one type of symptoms being worse on night and morning, symptoms varying over time and in intensity, symptoms triggered by viral infection or specific triggers like irritants, smoke, emotions, and all that. There are other things which may suggest that this may not be asthma, which includes isolated cough with no other respiratory symptoms or sputum production. So isolated cough can occur in, many conditions, but can also occur in asthma. Sputum production is a feature of bronchiectasis. So, that should be taken care of. Other things like TB also should be considered. uh, lightheadedness and all may indicate that this patient has uh, hyperventilation, maybe a historical thing. Chest pain may indicate TB or something else. Exercise-induced asthma may be there, but maybe also cardiac and other things. And also you're looking for stridor, which may be upper airway obstruction. So you have a typical way of evaluating your patient. I'll not go into depth of the algorithm, but if the patient is severely symptomatic, if peak flow spirometry is not available, then you can directly go ahead and give, if the typical symptoms are there, you can initiate treatment in your patient. On the other hand, if you can confirm the variability on your spirometry, then that is consistent with the diagnosis of asthma, and then you can start treatment with a firm diagnosis. In most other conditions, you have to also work up for alternate diagnosis. There are various ways of looking for spirometry, reversibility on spirometry. I'll just summarize that in a slide later. So this is how you get values in a spirometry. The NCD division, as part of our national program for COPD and asthma, is planning to provide spirometers in all districts. Dr. Avinash probably will be able to inform you how far we have progressed in that way. So the main things you are looking for is the reversibility, which indicates that the FEV1, which is the second value here, FEV1, should increase by 200 ml. In this patient, it has increased from 1.98 liters to 2.38 liters, which is an increase of 400 ml. And then this change should be more than 12%. In this particular patient, it is 20% increase. So when it has increased by more than 12% and 200 ml, you say there is a reversible airflow limitation. In this particular patient, spirometry is typical of asthma. On the other hand, for COPD, you will not get both of them together. In this particular patient, there is actually a 24% increase. But if you look at the volume has increased only by 140 ml, which means that there is no reversibility present. In COPD, you're looking for a persistent obstruction or a airflow limitation in the post-bronchodilator spirometry, and also lack of reversibility. Of course, you can get reversibility in COPD, but typically it's a feature of asthma. Spirometry, even though you want it to be done, the reality is it is not done in most places. So in Kerala, which is supposed to have a good health system, even in Kerala, 1/3 of pulmonologists do not do spirometry. It's a shame for my community. Every patient with asthma and COPD should have a spirometry done. But even pulmonologists, about 1/3 don't do spirometry. And when you go out to the general physician and for the general practitioner, only 15% of asthma COPD patients have got a spirometry done, which again indicates a lack of access to spirometry in our country. In terms of management, I'll just summarize in this one particular slide with a few more slides just indicating further points to see. So the main thing, like I said, in this both these ways of managing is the presence of inhaled corticosteroids. So here, the first track or the preferred way of management is called the MART therapy. So the maintenance and reliever therapy, which actually means that your single inhaler inhale corticosteroid with the formoterol. It could be a budesonide formoterol combination that actually acts both as your long-term preventive drug, which has to be taken regularly, and also your reliever drug, which is taken extra whenever patient has symptoms. So in asthma management, you have two ways of giving your inhaler. One is the controller medication, which is the medication which has to be given regularly to the patient to prevent the patient from having symptoms, and the reliever medication, which you give to your patient when the patient develops symptoms. So for when both of them are same, you call it the MART therapy. So generally, when you use inhaled corticosteroid formoterol combination, you can do the MART therapy. In the initial milder forms of asthma, you can give these medication as needed whenever patient has symptoms. But as the symptoms increase from step 3, step 4 onwards, you have to give regular inhaled corticosteroid formoterol, and the dosage keeps increasing based on. So stepwise treatment is, if your patient does not respond to your current line of management, you will go to the next step. If he doesn't respond to that step itself, you go to step 4, step 5, so you keep on going up. And if the patient has controlled symptoms for 3 months, then you keep stepping down to the bare minimum dose at which you can actually control the asthma. The second track is the less preferred track, but in that, the controller medication still remains inhaled corticosteroid with the LABA, but the reliever medication is inhaled corticosteroid with a short-acting beta agonist. LABA is a long-acting beta agonist and has to be a formoterol for MART therapy. Whereas for when you combine inhaled corticosteroid, budesonide or beclomethasone with salbutamol, when it is used as a reliever medication, then you call it the track 2, where you actually again do the stepping up and stepping down based on the response that the patient has. Again, the field reality is that only about 6% of COPD patients and 27% of asthma patients in Kerala actually received the correct treatment before they reached the medical college. Again, about half the patients still in Kerala were being treated with oral drugs, which is a shame in our country where inhalers are accessible, not too costly as compared to many other countries. So there, the theme of this year's World Asthma Day becomes a very apt that you have to increase access to inhaled medication. Of course, there are other things to look for. Patient education is extremely important, the most important step, in fact. Allergen avoidance is the second important, way of managing. And then you have the drugs that we mentioned already, and management of exacerbation is also something that you have to take care of. A few points on inhaled medication because that is a theme and the most important part of asthma management. So, inhaled medications over the years we have been using them for more than 40 years now. But the fact is that the technique of inhaler use has not really improved in our patients over the years. This is an international meta-analysis. So all over the world, the proportion of patients using inhaler properly is still around 30 to 40%, not still increased much. And that is a sad reality that we have to face. In Kerala also, when we did a study on this, we found that only 20% of our US patients are using inhalers perfectly, but 35% of them had an adequate technique, whereas 45% of them are using it extremely wrongly. So it's not just enough to prescribe an inhaler. It is very important to give training to your patient on how to use the inhaler appropriately. Now, in our program in Kerala, we wrote given an MDI with spacer, which is an easier way of taking an inhaler. But even that, you have to train the patient how to use it. And we have videos available in our state government website, which actually trains the people how to use the inhaler and all those things. So when your patient, you have started treatment appropriately for your patient and your patient is still not responding to treatment, then the first three things you look for is he using the inhaler regularly? Compliance is the first thing you look for. Second thing is his inhaler technique correct? And the third is, have we given him adequate dose of inhalers? Whether the dosage may be low and you may have to step up as per the stepwise therapy that you mentioned. Only after that, you will look at other steps. Exacerbation of asthma is common. It also results in mortality, even in children. So it's important to manage exacerbation properly. The moment patient comes with exacerbation, you have to assess the severity of the exacerbation and determine the level of care. So the level of care is determined by the severity. So if your patient is having cyanosis or a silent chest, extreme dyspnea, you may have to immediately refer the patient to a higher center where ventilator and other facilities are available. If the patient is less sick, can be managed at primary care level or a secondary care level. The key ingredients of management of a exacerbation are corticosteroid. You don't have to give injections and all. You just can give oral prednisolone about 0.5 to 1 milligram per kg. Bronchodilators given as nebulization. Again, you don't have to give injections for that. Oxygen if the patient has hypoxia. Antibiotics if the patient has fever and other features of infection. So this is in short how you manage exacerbation, and you need a short-term step up of your steroid inhaler to maybe double the dose to actually ensure that the patient is managed properly. I've kind of run out of time, so I'll not go into too deep into how we have been managing asthma at various primary care level, the experience sharing. I will directly go to the probably last slide and then summarize. So the point I just wanted to make a point that India, we have got now guidelines from the NCD division on COPD and asthma, which is now being revised, and new guidelines will be available. Gives you clear guidelines on how to, refer a patient, whom to screen, how to refer, and also will lead to provision of spirometry and inhaler therapy at various levels. So I'll not go into details of that because I've run out of time. So I'll conclude by saying that asthma is an important disease causing significant mortality and morbidity in our country. Diagnostic algorithms and treatment protocols from various agencies, international, national, are available for us. We have to give a guideline-based proper diagnosis and treatment. These guidelines can be implemented at primary care level. I wanted to give you some success stories because I ran out of time. But then there are success stories available in various states of India, and also the NCD division is bringing out guidelines which will help the healthcare providers in implementing care of asthma at lower levels also. Ensuring access to proper treatment, particularly inhaled corticosteroids, is extremely important for a patient, which can significantly prevent mortality in our country. Like I started with saying with the epidemiology, we have the dubious distinction of being one of the leading countries in the world in terms of asthma mortality. this is a mortality which definitely can be reduced, and maybe, large number of deaths in India can be prevented if we can manage our asthma properly. So thank you so much. Thank you for the patient listening. I thank the entire Schwarz team in Kerala for all the support in implementing the asthma care program in the community in Kerala. Thank you. I'm open for questions and suggestions.
Thank you so much, sir. Good afternoon, Dr. Ramesh, sir. Dr. Ramesh, sir, could you please confirm that we are audible to you? Because this is the time for the question and answer session. Dr. Pankaj? I think they are facing some bandwidth issue. So, sir, I would like to take one or two, three questions from the participant side. Just allow me to check if they have shared any question. Actually, sir, they have not shared any question in the chat box. I'm just trying to search.
Okay, there's a question which has come up now. So I think it's an interesting question on what if the patient has COPD
Right,
and asthma together.
right,
So
right.
earlier, a distinct entity called asthma COPD overlap was described. But then of late, we are not describing that entity, but
Sir,
people both are
yes,
common diseases, and you can actually have asthma and COPD together. Generally, when you have asthma and COPD together, COPD, like I said earlier, generally is managed with inhaled bronchodilators. Asthma is managed with steroids. So when you have both together, you will have to add both the components, and the patient will need bronchodilators and steroids as well. That is one of the indications in COPD to give inhaled corticosteroids. Generally,
sir.
you try to avoid in COPD, but you can actually do. Yeah,
Yes, sir. Yes, sir.
please.
So we have Dr. Ramesh, sir, and we have two
Yeah.
questions in the chat. Q&A. Dr.
Yeah.
Ramesh,
So,
sir. Yeah,
yeah, very good afternoon, Dr. Sanjeev. It was a very such an excellent presentation, and
Thank you,
if
sir.
you can, Abdeji, if you can allow my video also, I will be very grateful
sure, sure,
because
sir.
yeah. So now you have allowed me. Uh, I think I should be. Just a minute. No, I'm still not able to
Sir, just
open my
allow me
video.
a second. Yeah.
Yeah, sure. Anyway, Dr. Sanjeev, so you have actually uh, talked
Now
in
you can
depth
try,
about
sir.
the asthma, and it is quite yeah. Good evening, namaskar. Yeah. So about the mortality, you are certainly very right that in India, the asthma is still taking a lot of toll. And probably because of these seminars and the awareness which we are spreading through these webinars, the ministry is bringing up the new guidelines. So I think the dream that the mortality because of this preventable NCD will certainly come down. And identification, I think, is the most important factor, as you told in the first slide, that identifying the severity of the disease, I think, is very important as for our healthcare workers, that correctly identifying when the patient's treatment has to be escalated to the next step, to the secondary or the tertiary level. So that's certainly important, apart from the routine treatment, what is to be delivered at the hospitals or at the primary centers. Use of steroids, of course, is utmost important in management of asthma as compared to COPD, sir. And very rightly said that the use of devices, which as a clinician we do promote, but because of say unawareness, some more enthusiasm from both your side and from the ministry side, probably the people will be able to use the care of the asthma in a better manner. So we are very thankful to you, Dr. Sanjeev, for such an excellent presentation and making aware of the basics of the asthma and the management. I can take one or two questions if you allow me. So one is very interesting question is that how to use the big inhaler. So I don't understand what is this big inhaler, but I think what they are trying to say is a big inhaler is something with a spacer device. What they are telling you. So how to use a big inhaler? That's one question, sir.
Sure, whether they mean the breath actuated inhaler. So there is something called breath actuated inhaler, which is, I will not take the brand name here, but there are breath actuated inhalers where you don't have to trigger the inhaler. Generally, meter dose inhalers, we have to
Okay.
press the breath actuated inhaler. You just have to exhale fully, keep in your mouth and inhale it. That automatically it will be triggered when your breath is to a particular velocity, and then you continue breathing and take the whole thing. So breath actuated inhalers, in a way, get over the need for hand breath coordination, so that the inhaler will
Yes.
trigger itself when the patient is breathing. So that is a important way of getting over the problems of hand breath coordination. The other way of getting over the problems of hand breath coordination is using a meter dose inhaler with a spacer. Dry
Okay.
powder inhaler also can help in terms of less coordination required. But the problem is that with the dry powder inhalers, you need a inspiratory flow. So if a minimum inspiratory flow is not there, particularly your older COPD patients, younger asthma patients can use a dry powder inhaler equally well. But your older COPD patients may not be able to generate enough inspiratory flow, so their inhaler, the drug may just reach their mouth and throat. It may not really go inside their lungs. So that is, I think, I hope I covered that person's questions.
Very true, sir. A very pertinent question that I can see in the chat is that in a resource poor community setting, that's true also, in a resource poor community setting, what is the best way to diagnose asthma, like in a large camp? So what they are actually asking is that we have so many people in the camp coming. So how to screen them for asthma, sir? So I think this is a very genuine question.
So if you remember my slides, I
Yeah.
particularly started with symptoms. Because we are in India,
Mm.
all said and done, the NCD division and the government of India is taking a lot of efforts to bring in spirometry in a big way. But then even if spirometry comes at district hospital, the numbers that we have in India are so large that not all our patients will be able to reach the district hospital for spirometry. So at our primary care level, either we have to look for replacements for spirometry, like a peak flow meter or a mini spirometer. So we have used both of these in Kerala. So even international guidelines like GINA guidelines do allow for a peak flow meter with reversibility to diagnose asthma. We have used a mini peak spirometer in Kerala for the Schwarz program to diagnose asthma. But even if these things are not available, at the end of the day, asthma is a syndromic diagnosis. If your patient has a particular set of symptoms, variable symptoms, presence of wheeze and cough, uh, nocturnal symptoms, family history, history of other atopy. All these things are sufficient enough to help you make a diagnosis of asthma. Again, we have to understand that our country has limitation in terms of the number of patients who can provide inhalers also. So our concern always is that we should not overdiagnose asthma and give inhalers to people who do not have asthma. So both things are true. One, we should not miss asthma, and on the other hand, we should not overdiagnose and waste our precious resources in terms of inhalers for treatment. So I think clinically, with good clinical acumen, asthma can be diagnosed at primary care level. If there is any doubt, please send to the next level as spirometry can be done.
Yeah, very truly said, sir, that identifying the risk factors and the clinical features which can tell you or at least screen those patients and then escalating the treatment to the next level. So I think, Avdeshji, that we are running short of time. There are many queries in the chat box which can be taken later by sir on the email and on your platform. So I must thank Dr. Sanjeev for such an excellent presentation and making us aware of the asthma on this very prestigious day. And thanks to the eco team, Mr. Abdeji, who is always there to support us. Once again, we are very thankful to the Ministry of Health and Family Welfare and the Directorate General of Health Services, the DG and the additional DG, Dr. Swasticharan sir, who has taken this initiative to run the series of webinars. So with this, we close this session, and any emails can be, Mr. Abdeji, you can just tell how to see the slides which sir has and how to answer the queries. So from my side, it is thank you very much. Thank you, Dr. Sanjeev. Thank you.
Thank you,
Thank you.
thank you, thank you, sir.
Thank you so much, sir. Thank you, Dr. Ramesh, sir. Thank you, Dr. Sanjeev. So, dear participant, I would like just show you how you can get access of that particular slide, or you can download the content as well as you can drop your questions. So, whenever you just reach to particular your program on iEcho, just select MOHF2 Echo webinar. Maybe you have registered a several programs, so you have to select this particular one, and here you can access the or drop your questions in the conversation box, and sir will later take it on. We can share with the mail as well with the sir. And for the content, you can download the content here. It will be uploaded in the tab. You can also just take a review online as well as you can download at it. Thank you so much. So over to you, sir. With your permission, we can wind up the session. Dr. Ramesh, sir. Sir,
Yeah. Okay. So we are just winding up the session. Thank you, Dr. Sanjeev. Thank you, Avdeshi.
thank you
Thank
so
you.
much, sir.
Have a
Thank
good
you,
day.
the
Thank
participants,
you.
for joining.
Yeah. Thank you, the participants. Thank you.